Physical activity has been found to be associated with many health benefits. Some of those listed here, including lower rates of all-cause mortality, cardiovascular disease, type 2 diabetes, hypertension, stroke, and several forms of cancer. But about half of the people in the United States, half of the adults in the United States, don't reach the minimum level of physical activity to actually achieve these health benefits. Pedometers have been well studied for being able to increase physical activity and have actually been found to be associated with the clinical benefits of decreased BMI and lower systolic blood pressure. But they haven't gained much adoption from the general population. So it's worth thinking about why. Here are some of the characteristics along with pedometers. So one of the things that individuals have to do is they have to actively carry these things. They have to wake up every day and remember to put them on. There's a cost associated to these, which is not trivial. And then most of the studies around pedometers have found that their use is only effective if the individuals are given a step goal and they keep track of how many steps they walk a day. And most of that is done manually by logging it in a notebook and then looking at it. So the adoption in general population is low. Connected health has received a lot of hype for the hopeful potential of where they might be able to automate some of this stuff. So wearable devices have been talked about a lot during this session. The difference is that those are actively worn, and so some people may sleep with them, but oftentimes people still have to remember to wear these devices. Their cost is much higher. The Apple Watch, which people have talked about, starts at $349 and can be much more expensive. And there's also additional efforts that have to be put into these. So they have to be actively plugged in or synced to a computer or a phone. You have to regularly charge these. So you're asking individuals to do new behaviors, and these are individuals that have already opted in to say that they have difficulties doing new behaviors like physical activity. Only about 1% to 2% of adults in the United States have purchased a wearable device, and most of those people, 50%, stop using them within 3 to 6 months. Recently, smartphones have been enabled to be able to track steps. For anybody that has an iPhone 6, your smartphone is tracking your steps by default, and you actually can't turn it off, at least not yet. There's been many apps that can do this, and the difference here is that you passively carry this. You don't carry your phone to track your steps, you carry your phone because you want to have it around to check your email or to make phone calls or whatever else. The cost for this is, once you have the phone, is essentially free for the technology to do this. And there's essentially no effort required because all the data can be passively pulled via cellular and then be displayed back to you in a variety of different forms of feedback. And the adoption of smartphones is quite high. 65% of adults in the United States own a smartphone. So we wanted to evaluate using smartphones for this. So our broad goal was to evaluate the feasibility of a connected health approach using smartphones to track physical activity and using that to automate feedback for a 6-month period. We wanted to use a team-based model to promote peer support and a sense of accountability among the participants to engage in the intervention and use the devices. And then we aimed to compare strategies using financial incentives and social norms feedback to increase physical activity outcomes. Our specific aims were to evaluate whether framing social norms feedback using different benchmark levels would impact physical activity outcomes. And our hypothesis was that if we framed feedback relative to the 75th percentile, the top quartile, that would lead to higher proportion of participants meeting their goal than if we framed it to the median, which tends to be the standard. The second aim was to evaluate the impact of using financial incentives. And our hypothesis was that incentives that were informed from behavioral economics and used concepts such as variable rewards and regret aversion would result in a higher proportion of participants meeting their goal. We designed a 26-week randomized control trial from March to September of this year. Individuals were given a goal of walking 7,000 steps a day. 7,000 steps has been endorsed by the American College of Sports Medicine as the minimum level meeting the federal guidelines to achieve clinical benefits. People got 26 weeks of performance feedback, so every day individuals were told whether or not they met their 7,000 step goal yesterday. And at the end of each week, teams got social norms feedback, which I'll show you in an upcoming slide. Individuals got $25 to enroll in the study, and they got $75 to participate through 13 weeks. Because of our funding deadline, we couldn't put an end of study incentive here, so that's why it stops there. We enrolled 288 participants. These were either employees from the University of Pennsylvania Health System or their family members. They were excluded if they're already participating in a physical activity study, if they didn't have an iPhone or Android, which was required to use this software, or if they had any medical conditions prohibiting them from being in a physical activity study. The enrollment process went like this. We asked people to form teams on their own. They chose a captain who would go to the Way to Health platform and start the enrollment process, and then invite the other participants to participate. Everybody had to download the Moves app, which is what we used in this study, and then they had to enter a PIN which authorized the data to be sent to our servers so we could use that. People who didn't have a team or were interested in finding a team submitted their names and then were opted in to be in a list that we then sent back to those people, and they could then form teams from that. We used a 2x2 factorial design, so participants were randomized to either get 50 percentile or 75th percentile framing with and without incentives. These are the financial incentives were delivered in a weekly regret lottery with an expected value of about $1.40, which has been used in prior work. Each of the individuals had a 1 in 5 chance of winning $35 and a 1 in 100 chance of winning $350. But you were only eligible to collect if the average number of steps per member per team on your team was 7,000 steps per day for the past week. The social norms feedback was delivered either by text or email, depending on the participant's preference, and they might have gotten a message like this. Your team members averaged 6,825 steps this past week, which is above the 50th percentile of teams, which averaged 6,400 steps. If they won the lottery, they might get something like this. Congratulations, you won the $350 lottery this week. However, you're ineligible to collect because your team did not average at least 7,000 steps a day. So that's the regret version. The primary outcome was the proportion of participants achieving this minimum 7,000 step per day goal. The secondary outcome was the mean number of steps, and then the follow-up, and then both of those outcomes in the follow-up period. We used a generalized logistic and linear mixed models using fixed effects for the study arm and time by week. We adjusted the standard errors for repeated measures within a participant over time, and then also for participants that were within the same team. So this is the study flow. We randomized 288 individuals into one of the 4 arms. We had an issue here with randomization. We wanted to block randomize, but because this is the first study with teams, they were basic randomized and the study was started. So as you can see here, we have 100 individuals, 64, 80, and then 42. So the 50th percentile arms were slightly larger than the 75th percentile arms. The other thing I'll point out here is that we had a relatively low dropout. So in the intervention period, 8 people dropped out, and in the follow-up period, 3 people dropped out. So about 4% dropout, which was surprising to us given that there was no end of study incentive. So this is the sample characteristics. I won't spend too much time here except to point out a couple of things. The mean age was around in the mid-30s. About 75% of participants were female. And then if you look down at the bottom row, about 70 to 80% of people had an iPhone. Otherwise, the characteristics are pretty even across the arms. So I'll show you the unadjusted results first. So this is the proportion of the teams meeting their goal by week. Orienting you to the axes, on the y-axis is the proportion that met their goal from 0 to 1, and across the bottom is time. The black lines represent the 50th percentile framing, where the gray lines are the 75th percentile framing, and the dashes mean that they did not get an incentive. So there are a couple of things that you'll notice here. The first thing is most of the lines where they started is where they ended up. This continues throughout, so you'll see the top line is the 50th percentile with incentives, and they remained there throughout the period. And then the worst performing line was the 75th percentile without incentives, and it remained like that during the period. This is the unadjusted mean daily steps. So you'll see here, if you compare the 50th percentile with arms to the 75th percentile without, there was about 1,000 steps difference, and the bars represent the 95% confidence intervals. If you add in the follow-up period, you'll see there was about an 800 step drop-off for the 50th percentile arm, and actually in the follow-up period, the 75th percentile with incentives did slightly better. Again, these are unadjusted. Now moving into the adjusted results, this is the main model looking at the proportion meeting goal. And the main finding here is that that relative to 75th percentile without incentives, the 50th percentile with incentives had 3.3 times higher odds of meeting their 7,000 step goal. And it was slightly insignificant in the follow-up period with the p-value of 0.1. We adjusted this for device, so whether you had an iPhone or Android, just in case there were differences in measurement, and the sensitivity analysis did not change the main findings. This is the adjusted model for the difference in mean steps. So you'll see the 50th percentile with incentives had about 1,000 steps different, but slightly insignificant p-value of 0.07. We adjusted this for device as well, and then we also excluded observations of less than 1,000 steps. We found in the physical activity literature that this was a common method looking to remove people that from step levels that was essentially like too low to actually count, so they probably didn't use their device on that day, and got the same overall results. A few limitations. So we had the unequal randomization, which may have underpowered the 75th percentile arms. This was one of the first studies using smartphones to track steps over a long period, so we couldn't capture when people were walking without their phones in this study. There may have been differences between tracking between iPhones and Androids, anecdotally, although the model is adjusted for that and didn't find any differences in the main outcomes. So in summary, smartphones were a feasible method to track physical activity over this extended period. The team-based model, we had a low dropout, and while we specifically didn't compare that to not a team-based model, we think that played a role. There might be a future opportunity to further evaluate that and leverage social incentives. And then in terms of the engagement strategy, so compared to the 75th percentile without incentives, the 50th percentile had 3 times higher odds of achieving goal. So future studies might look more into the frequency of feedback and longer-term outcomes.